friend and colleague who, took the train in this morning and continue to that. He's a cardiologist and a clinical trialist at Brigham and Women's Hospital, and he's a co-director of the Center for Cardiometabolic Implementation Science at Brigham, and he's the co-chair of the Heart Failure Collaboratory Committee focused on improving future clinical trials in heart failure, and he's a panelist at the Global CVCT Forum. He's a section editor for the early career at JACC, an associate editor of JACC Heart Failure, and serves on the editorial board for EJHF. And his work has been, he's been really prolific in many domains, but specifically his work is focused on drug development, clinical trials, and learning about cardiometabolic renal therapies and their effects on different patient populations. He has co-authored, 500 publications, and he's we're just glad to have him here because he's talking to us about how can we make therapies more useful for patients by thinking about upfront combination therapies. Muthu, with that, very happy here.
Thank you so much, Rohan, and really great privilege to be here and to join you all both in person and virtually. I intentionally selected a perhaps controversial, forward-looking topic to tackle today about upfront combination medical therapy and really disrupting what we've traditionally seen in terms of drug sequencing, and really taking an approach of maybe one size may fit many individuals in clinical practice. Here are the key learning objectives. We'll first describe the rationale for simultaneously targeting multiple pathways with drug therapies early in the disease course. We'll then summarize some scientific approaches that can be taken to test and evaluate strategies of combination medical therapies. And then finally, discuss potential strategies to implement this approach at scale in a broad and equitable fashion. So this is the current chronic disease model of care in which we sequentially introduce medical therapies after disease identification, and we can superimpose essentially many chronic illnesses, including hypertension, in which the trigger of higher blood pressures may trigger you to add a second or third or fourth medication. Similarly, inadequate glycemic control may trigger us to add additional antihyperglycemic medical therapies. In the case of heart failure, worsening symptoms or even clinical events such as hospitalizations are often the trigger that set in place the need or requirement for additional medical therapies. However, there are many issues and complexities with this traditional or conventional approach of sequential addition of therapies. First and foremost, it is slow. And this is a conceptual model, for instance, in heart failure, in which if you lay out the guideline recommended windows of time, which you monitor these therapies over 2 to 4 weeks after initial initiation, if you take a sequential approach, full guideline-directed medical therapy optimization would take up to 6 months. And this certainly does play out in clinical practice as well. This was a recent multinational experience across the United States, Sweden, and the United Kingdom of about 70,000 individuals who were newly started on individual components of guideline-directed medical therapies. And the curves on the right show the actual new therapeutic initiation as well as optimization after that first index initiation. And in fact, you see that titration is relatively slow, new drug initiation is very infrequent, and in fact, drug discontinuation appears to be the predominant pattern for many of these therapies. Furthermore, it is clinically evident, and even in heart failure where there's large degree of clinical inertia, when drug therapy is optimized, it typically does occur at the time of hospitalizations. Here you can see in turquoise is 6 months prior to a hospitalization event. Then in the light green is 3 months prior to a hospitalization event. In red is the hospitalization encounter, and then 3 months after in dark green. And you can see that there's relative stagnation before hospitalization, There's some optimization and then it falls off again or persists in some cases. And so this is the, even when therapies are optimized, they're still occurring at times of clinical events. And those clinical events are the same events we hope to prevent with medical therapies. Furthermore, this slow sequential approach may expose patients to early risk during that period of optimization. This was a simulation exercise across 6 pivotal heart failure trials in which we sequenced, we evaluated about over 10 different sequences of medical therapies based on pivotal trial results in terms of treatment effects of the individual drugs. And we found that just the delay required to sequence and initiate in 4 drugs, one after another, would introduce an excess of up to 14 deaths and 47 patients experiencing a heart failure event per 1,000 patients treated over just 12 months. So this is of course, a simulation, but does suggest that there's an early penalty to delaying optimization, at least in high-risk entities like heart failure. Furthermore, we know drug optimization is subject to high variability in practice. In fact, these are data from the NCDR-DCR registry. It's a large contemporary registry of patients with type 2 diabetes, over 50,000 individuals and over 350 practices across the US. And you can see that this is the use of SGLT2 inhibitors and GLP-1 receptor agonists. There's a large cohort of hospitals and sites that have never used these drugs in eligible patients. And then there's substantial variability even amongst the practices that do use these therapies. And certainly the combination use of these therapies are subject to high variability. Investigators, as a part of the CARDS lab led by Dr. Kara and colleagues, have also demonstrated that this conventional sequential approach may also potentially introduce inequities in care. Here was a very interesting study that was a nationwide study of SGLT2 inhibitor use patterns across major populations that evaluated county level characteristics that may predict higher or lower use at the county level. And what they did was they indexed it to metformin use patterns. And they found, in fact, that SGLT2 inhibitor use was less frequent in Black predominant counties and rural counties, perhaps highlighting these inequities in care when we take non-standard approaches. So can we learn from adjacent disciplines of alternative approaches, moving beyond this sequential conventional approach? For instance, in the care of chronic obstructive pulmonary disease, COPD, in the contemporary era, so-called triple therapy, an inhaled corticosteroid, a LAMA or a long-acting muscarinic agonist, and a long-acting beta agonist, is now standard of care for many high-risk individuals, especially those who've experienced an exacerbation of COPD. In fact, this is predicated on 2 large-scale randomized clinical trials, IMPACT and ETHOS, that did demonstrate a mortality reduction of 3 drugs taken together versus 2 drug combinations of bronchodilation. Similarly, of course, we have a long-standing history with HIV and AIDS, with HAART being introduced in 1996. So it's not actually been that long since initial introduction. And you can see that even in the contemporary era, you can see there's stepwise modification of the disease trajectory of HIV with introduction of combination medical therapies as a standard of care in HIV. So why might this be an optimal approach in the care of cardiometabolic diseases? Certainly, the patients we care for have complex disease states. They're not often driven by single pathophysiological processes. In the case of heart failure, of course, there's inputs from the sympathetic nervous system, the renin-angiotensin system, the neprilysin axis, the mineralocorticoid receptor, and the SGLT2 system. So using individual drugs to target complex disease states may not even have a theoretical basis. Furthermore, we know that these drugs act very rapidly, and we've seen this time and time again, that there's early opportunities to modify disease progression. These were most recent data from the DELIVER trial, in which we found that the SGLT2 inhibitor dapagliflozin had statistically significant benefits within just 2 weeks of randomization. And this is to show that using these drugs at an earlier time point, even waiting for that follow-up visit, may expose patients to unnecessary risks. Furthermore, there's early event reductions, including in sudden death and ventricular arrhythmias, that could be prevented with early optimization. These are data from the DAPA-HF trial, in which, again, the SGLT2 inhibitor dapagliflozin reduced the risk of ventricular arrhythmia, resuscitated cardiac arrest, and sudden death. And this may have downstream implications for other aspects of care as well. Furthermore, it's apparent across disease states of cardiometabolism that there are evident benefits even at low doses. And this is the case even when we don't have structured dose response trials with respect to outcomes. For instance, in the emphasis heart failure trial evaluating an MRA, and MRAs really don't have trials that have tested directly low versus high doses of MRA and clinical outcomes in heart failure. But in the emphasis heart failure trial, there was actually a dose stratification based on baseline kidney function, such that those with poorer kidney function at baseline were randomized to lower doses of the MRA eplerenone. And in fact, you can see that the clinical benefits were seen even in that low dose stratum. Furthermore, in the evaluation of ARNI, or sacubitril valsartan, in heart failure, again, we don't have solid clinical trial evidence comparing low, middle versus high doses of sacubitril valsartan. However, during the course of the trial, some patients weren't able to attain target doses of the drug. And so those that even attained lower doses or middle doses of the drug still did appear to obtain clinical benefits. Furthermore, there is a potential to minimize side effects using low-dose combination drugs. This was best highlighted in the recent Quartet trial. This was an Australian trial of 591 adults in which a quadruple pill or a quad pill of irbesartan at a low dose, amlodipine at a miniature dose, indapamide, and bisoprolol were compared against monotherapy irbesartan at target dose. And you can see two key findings. One is in the blue, you can see this is the initial quad pill versus the initial irbesartan with the allowance for stepwise initiation, as is typical in usual care. You can see not only was the time to blood pressure lowering more rapid with initial quad pill, but also the safety was remarkably well tolerated with using 4 drugs at ultra low doses. And you can see that there was only over 12 weeks, there were only 7 serious adverse events in the intervention group and 3 serious adverse events in the control group. And there was no difference in those requiring drug discontinuation. There is also potential for a synergistic potential of using 2 drugs together. For instance, we've seen the SGLT2 inhibitors as well as ARNI, sacubitril valsartan, reduces incident hyperkalemia and lowers potassium levels in treated patients. This was a very nice individual pooled meta-analysis of about 50,000 participants across the SGLT2 inhibitor trials that showed a modest reduction in serious hyperkalemia of about 15% and no increase in hypokalemia risks. And this was evident across patient subgroups, including those already treated with MRAs or RAS inhibitors. More directly testing this concept, we also have randomized clinical trials. This one is called Rotate 3. That was a very elegant trial, small trial of 46 individuals that were exposed to a period of dapagliflozin, the SGLT2 inhibitor, a period of eplerenone, the MRA alone, and then the combination together. And this sequence was rotated during the course of the trial. And so during periods in which patients were on dapagliflozin alone, there was a albuminuria reduction, similar to when they were on an MRA alone. but the combination provided additive potential in terms of UACR or albuminuria lowering. Importantly, there was a safety signal in terms of elevations in hyperkalemia, as would be expected with the eplerenone, but the combination use of dapagliflozin plus eplerenone attenuated those risks. And we can see this play out in terms of the clinical trials themselves. These are data from the EMPEROR program of the SGLT2 inhibitor empagliflozin, actually showed that patients who were already on an MRA at baseline had about a 22% lower risk of discontinuation of that MRA during the course of the trial if they were in the empagliflozin arm compared with the placebo arm. And this is potentially related to lower risks of serious hyperkalemia with the SGLT2 inhibitor. So there are other potential benefits that I won't get into. There's potential to minimize or limit drug resistance. This is not particularly relevant in many of our conditions of cardiometabolism, but is, of course, important in other adjacent disciplines like infectious diseases. Because of the early arrhythmia modification, as well as modification of certain modes of death, there's potential to influence downstream decision-making, such as timing of an ICD, if using combination versus sequential approaches. And there's a potential to promote standardization of care. And this is a concept that I added a question mark because I think this does need to be tested, whether this type of combination approach would allow for more equitable and standard care across populations. So how can we test combination medical therapy in clinical practice? We are used to single drug evaluation, especially against a placebo comparator, as a standard regulatory trial for drug approval. However, combination medical therapies require more nuanced approaches. And in an ideal setting, combination medical therapies should be tested in dedicated, rigorous trials against a previous accepted standard of care to ensure incremental benefits with acceptable additional safety profile. This is being actively done in a number of randomized clinical trials, and I'll take you through different flavors of these trials to give you a sense. We're conducting a trial called Confidence that's combining the use of the SGLT2 inhibitor empagliflozin with that of the non-steroidal MRA finerenone, and evaluating the combination versus each drug alone on a UACR endpoint, an albuminuria-based endpoint. This is in about 800 individuals, and the hope is that this would help to show the incremental potential of combination therapy in chronic kidney disease on a endpoint that is well validated, that is UACR. UACR is closely interlinked with subsequent kidney disease progression and is actually accepted almost to the bar that it could provide support for regulatory approval in for compounds with acceptable safety. There are also trials underway to understand whether combination medical therapies may actually improve cardiovascular outcomes. And this whole combination approach becomes a little more nuanced and difficult to study when we don't have well-accepted surrogates and disease states where we're still understanding optimal surrogates. For instance, in type 2 diabetes and obesity, A1C and weight loss alone may not be acceptable surrogates for cardiovascular outcome reduction. And so in this program, testing the combination use of two incretin, GIP agonism as well as GLP-1 agonism in obesity and type 2 diabetes, investigators are taking the strategy to actually target a large cardiovascular outcomes trial, comparing the combination versus the GLP-1 receptor agonist alone, which is the current standard of care. And in fact, this is the SURPASS platform. This is the type 2 diabetes component of this combination approach called tirzepatide, which is a dual incretin agonist. And you can see there are a number of ongoing trials. Many are active control trials against various standards of care, but I'll point you to this bottom trial, which is the actual cardiovascular outcomes trial, which is due to complete in 2025 and is randomized over 13,000 individuals against an active comparator of a GLP-1 receptor agonist in individuals with type 2 diabetes and established cardiovascular disease. Similarly, upfront strategies of whether to select an SGLT2 inhibitor or a GLP-1 receptor agonist, or both in a patient population of type 2 diabetes is also being studied in a trial called Precedent. This is again a large 9,000 patient trial testing a strategy of combination drug versus either drug alone on hard clinical outcomes. This is a total endpoint of deaths as well as cardiovascular renal endpoints. This is a PCORI-funded trial and does provide some hope for the future that these types of funding sources may be optimal to evaluate combination approaches in clinical practice. And the last trial I'll point us to is a trial that's ongoing with a new therapeutic compound. This is with an MR modulator. This is a slightly different compound than an MRA. It has theoretically a better hyperkalemia profile and has a very, very short half-life of MR receptor activation, MR receptor inhibition. And this trial is the phase 2 trial. It's called Miracle. It's about 540 individuals being randomized to the combination of the mineralocorticoid receptor modulator and an SGLT2 inhibitor at 3 different doses compared with the SGLT2 inhibitor alone. And this trial will be moving forward to a large phase 3 trial that will again be an active controlled trial against an SGLT2 inhibitor. So the case of heart failure was curious because the standard of care was quite different and evolved over time. And so this made it challenging to design dedicated active control trials. Whereas ACE inhibitors and ARBs were relatively standardized across trials, meaning each of these trials tested the incremental potential to a large extent of the novel drug versus standard of care, which included an ACE inhibitor or ARB. Same was largely true for the more contemporary beta block trials in terms of beta blocker use. Most recent trials did evaluate to a large extent high degree of background use of beta blockers. However, for the MRAs, this took a while and still is about at 70% in terms of background use. And so some patients are not treated on an MRA that are entering a trial of a new drug being studied. And the same is true for the more recent additions, such as ARNI. Here you can see sacubitril/valsartan, even in the more recent trials, were only used in about 1 in 5 individuals. And so the large majority of patients entering these trials are ARNI naive, and we're testing a new drug on the background of potentially suboptimal background therapy. And so we do need to rely on subgroup data to substantiate the incremental benefits of the new drug. And here this is just the example in terms of the MRA and ARNI in the evaluation of the SGLT2 inhibitor. This was the meta-analysis of 5 randomized clinical trials of SGLT2 inhibitors. And you can see that the benefits of the drug were seen irrespective of whether the patient was or was not or was on an MRA, and there was no evidence of treatment heterogeneity. And same is true for patients treated or not treated with ARNI at baseline. And while these proportions are low in individual trials, really the totality of evidence suggests no heterogeneity or no, certainly no drug-drug interaction, but also no clinical offset of using one drug in combination with the other. And so we can use this indirect evidence to suggest that these drugs may act truly in additive fashion. And we have simulated these data in, again, taking multiple pivotal randomized clinical trials of heart failure and saying, if we use these drugs in combination, what would be the total aggregate effects. And you can see here, there are really substantial aggregate risk reductions, over a 50% mortality reduction with full optimization of guideline-directed medical therapies if these drugs truly afforded additive treatment effect potential. And over a lifetime use, we actually see this is a substantial gain in overall survival. Again, compared with the prior standard of care of an ACE inhibitor, ARB, and beta blocker alone, the full combination use of an ARNI, beta blocker, MRA, and an SGLT2 inhibitor would afford up to 6 years of additional survival in a middle-aged individual with heart failure. So there are many innovative trial approaches that are now underway to better understand how we can potentially disrupt conventional approaches. At the top here would be the sequential approach. This is the traditional sequencing approach of starting one drug, starting the second, third, so forth. The evaluation of sequencing, upfront early optimization, or even different sequences is something that is actually more challenging to do in heart failure, especially in terms of studying clinical outcomes, because we don't have well-validated surrogates. Natriuretic peptides, unfortunately, while they're excellent and often do predict clinical outcomes, they're not perfect surrogates. And also, of course, there's substantial interest in the community around polypill strategies as an effective dissemination approach. So I'll bring our attention to a few trials that are taking novel implementation approaches to evaluation of combination drug therapies. This is a trial called STRONG-HF that will actually be presented at the American Heart Association meeting later this week, and already has been publicly announced to be stopped early for overwhelming efficacy. The trial design is fairly unique. These investigators, instead of taking kind of a gentle approach to optimization, they said, why don't we take an oncologic or cancer approach where you treat a patient with chemotherapy and only de-escalate the therapy if the patient has intolerable side effects to that approach. And so they actually initiated and rapidly titrated patients within a very short time frame to target doses of multiple drug therapies, and then continue to follow patients closely over several months after hospitalization with frequent laboratory monitoring as well as hemodynamic monitoring and in-person clinic visits, and only de-escalated therapy if there was intolerant hyperkalemia, worsening kidney function, or hemodynamics. And with this approach, we'll see what the overt results are, but the press release did indicate there was a reduction in clinical outcomes, even with a relatively short follow-up period. And so it does provide substantial rationale, if this can be done safely, that early optimization of drug therapies is a promising therapeutic strategy. There's also great interest in polypill strategies. We've seen this in multiple areas in cardiology and beyond. And in addition, there is interest in a heart failure polypill. This has been traditionally challenging because many of the drug therapies that have been proven to be effective in heart failure are still on brand. And so combining them, especially across sponsors, has been technically challenging. However, now as we move towards patent expiration for multiple SGLT2 inhibitors, as well as ARNI, this actually is could be feasibly done and is on the horizon. So colleagues at UT Southwestern, led by Dr. Ambrish Pandey, are conducting a polypill trial. This is an NIH-funded trial of a modest sample of patients being randomized to a combination use of 3 different doses of metoprolol succinate, spironolactone at a low fixed dose, and empagliflozin at the only dose studied. And this polypill is being compared with usual care. So patients may be titrated and initiated on therapies in accordance with usual clinical standards. This is actually being conducted in a unique, diverse, relatively uninsured patient population, so has broad implications in terms of equitable standardization of care. And the primary endpoint is an imaging-based endpoint, understanding does upfront optimization with a polypill allow for improved remodeling. This is being done with a sensitive tool, so cardiac MRI, to minimize variability and improve the power and the detection of a signal. So there are many challenges to this approach, and I recognize that this is a one-size-fits-all approach is not applicable to all patients. It ignores intrinsic biological variability in disease presentation, but perhaps more importantly, risk of progression. We may be over-treating patients who are low risk, who may never experience a clinical event in follow-up. It might not be acceptable to a patient or clinician, from a patient or clinician perspective, who are used to the sequential approach, and may feed into really concepts of polypharmacy and over-medicalization. And of course, it does add upfront costs to therapeutic care. And so really, in order to demonstrate value, it must be counterbalanced with a reduction in clinical events down the line. Thankfully, we do have a strong regulatory pathway that provides clear guidance of how combination drug therapies should be evaluated and can be studied. And this does provide sponsors some pathways forward in terms of evaluation of new drug therapies, including of old and new therapeutic compounds. And this has been most utilized outside of cardiology. Predominantly, actually, over half of combination therapies have been studied in oncologic care, but are beginning to be undertaken as well in cardiometabolic care. So in terms of the issues around costs, cost effectiveness, and value, traditionally, we have evaluated costs and cost effectiveness in single dimensions for single drug therapies. And in fact, this most recent iteration of the US heart failure guidelines were the first guidelines to introduce value statements to actually evaluate the published literature of cost effectiveness for each individual recommended drug therapy. And most of the drug therapies, when used alone, were high value, and the SGLT2 inhibitors were intermediate value. So taken together, we would assume that these drugs would provide relatively high value care, but these really need to be rigorously studied, especially in health context unique to the United States, in which we can understand the true incremental cost effectiveness of combination drug therapies. Colleagues here have really demonstrated that in current care for drugs, even with Medicare insurance, patients experience very high out-of-pocket costs. And so you can see the various cost estimates of out-of-pocket expenditures here, over $2,000 for standard of care, what guidelines are recommending as class 1 recommendations. And then even triple therapy combinations are still over $1,000 of out-of-pocket costs annually. And even an all generic triple therapy, beta blocker, ACE inhibitor, and MRA lead to a median out-of-pocket expenditure of $150. So how can we actually develop a rationale for the acceptability and including in terms of the costs of using upfront combination drugs, including in averting subsequent clinical events? The other opportunities are to actually minimize or discontinue ineffective medical therapies that have less proven data. And so these are data from the EMPEREG outcome trial led by Silvio. These data showed that the use of the SGLT2 inhibitor in type 2 diabetes care would markedly delay or even prevent the new initiation of insulin. And so this does provide some additional value arguments for using upfront drug therapy to potentially prevent or avert future high-cost expenditure therapies. Furthermore, while the whole proposition of a patient with multiple comorbidities to be on multiple medications for each individual comorbidity seems overburdensome. However, it's important that these entities strongly overlap in clinical practice, and individual drug therapies are indeed already approved and indicated for the simultaneous treatment of multiple therapies. And so while the prospect of using multiple medical therapies for each individual entity is potentially overburdensome, in fact, we can actually streamline care because many could be purposed for multiple conditions. I do wanted to, in these kind of final moments, I wanted to take some approaches from adjacent disciplines and guidelines that I think are promising in terms of more rational strategy, instead of a one-size-fits-all in which we say every person diagnosed with type 2 diabetes should be on an SGLT2 inhibitor and GLP-1 receptor agonist, or everyone with obesity should be on a dual incretin, a GLP-1 plus GIP agonist. I think a more rational strategy is a risk-based approach where combination medical therapy is used commensurate with the risk of progression of the patient. And so this is actually the most recent COPD guidelines. These are the 2022 GOLD guidelines, in which that strategy of risk-based optimization is actually embraced. And so they divided these populations into group A, B, C, and D based on the number of exacerbations, and then a validated risk score. And so you can see group D is the highest risk patients, and those patients are recommended upfront to be on 2-drug combination therapy. And then in follow-up, that's the initial strategy. In follow-up, based on subsequent symptom assessment, based on persistence of dyspnea or interval exacerbation, then the recommendations of 3-drug combination therapy that I alluded to in the beginning are then recommended. And this risk-based strategy, including a clear direction in terms of follow-up care, should of course be tested, but it does offer one pathway forward that helps to optimize the use of combination medical therapies in those at highest risk for clinical disease progression. So today, many entities and guidelines have already embraced a strategy of combination medical therapy. In fact, we've seen in the heart failure guidelines for both reduced ejection fraction as well as mildly reduced ejection fraction, concept of quadruple therapy is recommended at a high level of evidence. For chronic kidney disease as well, we've seen most recent KDIGO guidelines, for the most part, also recommending on the background of an ACE inhibitor or ARB, the optimization of a non-steroidal MRA and an SGLT2 inhibitor is recommended in many individuals, especially those at risk, those with persistent albuminuria. So this combination medical therapy approach is likely to expand to adjacent cardio-renal-metabolic entities like type 2 diabetes and obesity. I think we as a community really need to have a very structured and rigorous, not only regulatory, but also health economic approach to their evaluation. So the key conclusions are that the traditional approach or conventional approach to the management of many cardio-renal-metabolic diseases have relied on stepwise initiation of therapies. They're often triggered by either worsening laboratory measures like A1C increases, worsening symptoms, or interval clinical events. And this conventional approach is slow, unfortunately subject to substantial clinical inertia, and may not be optimal for patient outcomes. And so I do believe that an upfront combination medical therapy approach is potentially beneficial for many patients with cardiometabolic diseases. And this is a strategy that is subject to a number of ongoing clinical trials. The overall societal and patient acceptance of this approach, as well as issues around polypharmacy, cost, and access, require, of course, careful attention, but I think also represent key opportunities for disruption and innovation. I think we can really learn from adjacent disciplines in our patient management. So I hope that this stimulated some interest, some thoughts on your perspective. So I'd love to hear any questions or comments. Thank you so much.
Great talk, Muthu, really stimulating. I think that we've been dealing with this in diabetes for years. There have been schools of thought that say that we need to begin early on in the disease course with combination therapy. And I think the challenges there is that the lack of clinical trials. There have been some small trials suggesting better A1C control over a relatively brief period of time, maybe 2 years. And the naysayers would say, so what? You have a 0.3, 0.4 lowering of A1C. How's that going to translate to long-term risk? I think one of the things that has held us back in this area of combination therapy is how we speak to patients, the language that we use. And I think, your study, not just from EMPA-REG, which looked at insulin therapy, which is really important to patients, is avoiding insulin, but also from the heart failure trials showing a dramatic reduction. It's a modeling exercise, admittedly, but dramatic reduction in mortality. And I think when we talk about disease progression, that's what people are concerned about: disease progression, mortality. And that's what's helped the HIV field, is that patients know that the more medications they take, the longer they will live, the less opportunistic infections, and also obviously the convenience of a poly pill. And I think once we get accustomed to speaking to patients about disease progression, not just focusing on hemoglobin A1C, which is kind of an abstract concept to many patients, but also getting single pharmaceutical products to have dual or triple therapy, because patients really don't care about how many medications are in one pill. They just know that they are swallowing a single pill, and to them it's a single medication. So the question for you is, what is the language that you use when you're talking to patients in the clinic about all these new pharmaceuticals and the pushback that patients might give you?
Yeah, it's a wonderful question, Silvio, and I agree with you that we really do need to take time to learn from lessons learned in diabetes, hypertension, in which combination medical therapies have been pioneered and continue to be at a very high use at a global level. I think the lessons from heart failure in terms of now adapting to the current guidelines of saying 4 drugs up front for all patients with heart failure with reduced ejection fraction really takes a substantial amount of time at that first clinical encounter, in which patients should be made very clear that this is the chart moving forward, that 4 drugs are going to be introduced very quickly. And with that being the expectation, then patients do look forward to that, and there's much less surprise on, oh, why do I need to take another drug? I'm feeling okay. And so painting that picture very early, providing that rationale, I think is quite helpful. I think that acceptability, I 100% agree, will improve greatly with poly pills once introduced, and I do have strong faith that they will be introduced in entities like heart failure. In addition, I think we can learn again from other disciplines that there are alternative ways to deliver therapies that could be even longer acting. There are ongoing very early phase pilot studies, for instance, evaluating long-acting SGLT2 inhibitors that can be used over 2-week periods of time as either single ingestions or injection use. And again, I think that type of approach will facilitate better patient acceptance.
Wonderful talk. Thank you for being here with us this morning. I'm going to follow up on a thread on Dr. Nizuki introduced, which is the issue of monitoring and having conversations around disease progression. And so the challenge is, I'm a big believer upfront. With the evidence that's still developing, I think it is a pathway we have to pursue. But the challenges we have with atherosclerotic cardiovascular disease, and particularly with heart failure, is we can't monitor disease progression. Disease progression monitoring is a failure. It's heart failure admission or sudden event. Unlike A1C or FEV1 in your examples in other disciplines. How do you see the intersection of these combination approaches with what really is, I think, needed is kind of more nuanced assessments of progression, and how do we develop that?
It's thank you again for having me. It's an extreme honor. So I think the in terms of the disciplines, of course, would well-validated surrogates. There, the introduction of combination therapies guided by those surrogates seems like a rational approach. For instance, UACR is now in the ADA guidelines with a specific percentage reduction to target in clinical practice. And so using evidence-based drugs to target that approach, and in patients who have really no evident persistent albuminuria are probably at very low risks for kidney disease progression and may not require subsequent therapies. In disease states where we don't have those types of well-validated surrogates, I think that trials like STRONG-HF, which my understanding did draw regular biomarkers as well to guide that strategy as almost a guided 2.0 trial, can help provide a rationale for those types of markers to be used alongside our clinical monitoring. I do think that this is a major call, that while we have a growing set of therapeutic armamentarium, I think our a set in terms of monitoring is woefully kind of behind. And as we expand really telemedicine virtual care options, I think even tracking patients in terms of patient-reported outcomes that can be sensitive to changes in medical therapy on a day-to-day basis, I think that might also be another potential approach in addition to biomarkers. But I agree, it's a challenging space to say that 4 drugs shouldn't be used based on, let's say, low natriuretic peptides in current care.
Great talk, actually, and I'm going to be also like you, controversial now. And the fact is that, you know, in your combination therapy, and actually I'm a proponent of SGLT2 inhibitors, especially in heart failure patients, so nothing, don't take it wrong, but in your combination therapy, we are getting away from metformin, for example, use. So we practically are just looking at the trials, the result, and not pathophysiology. And I wanted to say that, you know, when you look at the results for from the incretins, GLP-1 agonists, this effect size for coronary arteries is small for event. It's not that huge. I mean, SGLT2 inhibitor have a major benefit. And not every diabetic patient gets kind of coronary artery disease, only about 12%. So I'm going to step back and say maybe actually still doing individual therapy, at least balance it toward the kind of one pill for everybody for a specific kind of disease. I mean, I agree with you. You have a heart failure patient, put it on, you know, SGLT2 inhibitor. When it comes to the diabetes patient, and you know, then you have to actually. I'm actually surprised that, you know, especially because, you know, so let's say for example, SGLT2 inhibitor, they make you to urinate glucose. Well, a lot of my patients with diabetes have problems with fatigue. They don't get the glucose into their skeletal muscle, whereby metformin could even help them with maybe symptoms. So I want to kind of say that there are a lot of things we have to take into consideration when we suggest such an approach.
I agree. This combination approach does risk oversimplification of biology and physiology. What I would say is that in high enough risk entities like heart failure, perhaps certain chronic kidney disease subsets, there seems to be greater acceptance in terms of the community of using these drugs up front. In lower risk entities, like patients, for instance, like you mentioned, with type 2 diabetes who do not have atherosclerotic cardiovascular disease, their risk of progression to developing a clinical event is highly variable. And so there, I think it is challenging to suggest that in all those patients, we should be using an SGLT2 inhibitor, for instance. And I think that dedicated trials are needed to actually test that low risk population, for instance. And that is being done. You know, there's a trial, for instance, registry randomized trial called SMARTEST. It's a 4,000 patient trial randomizing patient after first initial diagnosis of type 2 diabetes to an SGLT2 inhibitor versus metformin. And so understanding in that low risk of progression patient population, whether upfront randomization to an SGLT2 inhibitor, first line use of an SGLT2 inhibitor is actually a warranted strategy. But I agree from an economic perspective at a societal level, treating all is not, I think, going to be an acceptable approach, especially in broad entities like type 2 diabetes and obesity. We really do need to be risk-based, is my own suggestion, and selectively treat those at highest risk for progression. And I think that can be helped greatly by dedicated trials.
Excellent. Doc. I'll ask a follow-up question. So, I mean, you make a very strong case for upfront combination therapy and using both either a polypill strategy or rapid escalation. And polypill seems more likely to have acceptability and a path that makes it easier than the current standard. So, but on the commercial side, what's the appetite for something like a polypill? And a linked question is, what are the implications of that for financial and cost implications? Like, because we're finally at a moment that we have generic therapies for all heart failure class, at least most of them. So, just who would make the polypill and what does it mean for cost for us?
Yes, it's a wonderful question. I actually had some slides in about this specific issue, but then I thought it would get a little too far into the economic and regulatory issues. So from a commercial standpoint, there's great appetite because of the issues you alluded to, that polypills do allow for the potential for extension of patents of otherwise expiring generic therapies. And so that is an approach that I think that many sponsors would embrace, especially in attempting to expand indications to, for instance, higher risk populations. And I'll give you an example there. I mentioned the MR modulator called balcinrenone that is being studied as a combination drug with dapagliflozin and is being evaluated in a high-risk heart failure chronic kidney disease population. That's a population that we don't use MRAs in traditionally due to high risks of hyperkalemia. And so this is an opportunity to use two drugs for an indication that previously MRAs did not have. However, there's great concern around that potentially expanding the costs of heart failure therapeutic care. I think that the diabetes and hypertension worlds have seen this, especially after initial introduction of those combination pills, that they remained very high cost, especially in terms of out-of-pocket costs. Now down the line, now that many of those combinations are generic, it does make for a very affordable approach to improve adherence and on maintaining treatment.
It just popped up. Sam on. Oh, there's like a 47. Something about the cardio mems. I'm sorry, I can't read from here. Can you read up if you don't mind?
Yes. So the first question is, oh, perfect. So this question is, we are now on the cusp of having a surrogate endpoint for heart failure trials. With the advent of CardioMEMS, for the first time, we're able to monitor patients with ambulatory PA pressures. So it's a great question. And I think that it is CardioMEMS has a definite role in clinical practice, especially for high-risk patients where frequent diuretic titration is challenging. I think as a surrogate for assessment of clinical outcomes or prediction of clinical outcomes, I think it's a little more challenging because we know that patients, even who have normal filling pressures, do benefit from medical therapies and heart failure. And I think that that is the key concept that probably will move us away from using CardioMEMS as a surrogate for new drug evaluation.
Really great topic because just kind of building off of what you said, Silvio, is that there's so many efficacy trials, but there's not a lot of trials around the psychological aspects of increasing sequentially, both on the level of the clinician as well as the patient. But it also probably speaks to the way that we frame these diseases. And I think your talk title, Cardiometabolic, really emphasizes that, because we are so singularly minded around A1C, but rarely do we take into account that entire cardiometabolic profile. Like, how active are they? Are they able to walk a mile? Can they go up their stairs without getting short of breath? And so I think we need to reconceive how we track outcomes or how we assess disease risk. So if we put people into those quadrants, we're not so monolithic, and how we're thinking about their risk.
Yeah, it's 100%. I think on point. There are probably going to be many dimensions to that. Let's say, as we saw with the COPD guidelines, that 2x2 table, and I think that patient preference, acceptability, and upfront conversations will be a critical aspect, and they may ultimately guide what they may accept an upfront risk. But then want to sequence drugs based on how they're doing. And that might be an acceptable approach to some patients. I think as this, we're at a wonderful time, I think, in cardiometabolism, in which we have really, really effective drug therapies. Now we're rethinking concepts around implementation, but I think those patient conversations and structuring those initial conversations, especially on disease onset, I think is going to be a critical next step forward. Yes.
Thanks again for everyone who joined in person and virtually. I think this was an excellent grand rounds, and I look forward to seeing you back next week. If as the next year approaches, if there are other additional folks that you would want us to have on this podium, please let us know. We'll continue to have a rolling cycle of getting people in. Thank you.
Thank you all.